Good morning, everyone. Welcome to the Epidemiology and Public Health keynote speaker. We're very lucky today to have with us Dr. Husbands, who's an associate professor in the Dalai Lama School of Public Health at the University of Toronto, and until recently was a senior scientist at the Ontario HIV Treatment Network. He's also been involved on the front lines of HIV advocacy and community engagement through his roles as the Director of Research at the AIDS Committee of Toronto, founding co-chair of the African and Caribbean Council on HIV in Ontario, and a member of the Board of Directors at the Black Coalition for AIDS Prevention. Dr. Husbands also advocates for Black food justice through his membership of the Black Food Sovereignty Working Group that co-developed Toronto's Black Food Sovereignty Plan in 2021. We're very lucky to have him here speaking to us today. Dr. Husbands, please, you may begin.
Thank you, Jessica, and thank you, Lawrence. This is an honor to be invited to give this presentation today. I will okay, I hope that everybody can see this and everybody can hear me, okay? So I would like to begin by thanking the people who nominated me to deliver this keynote presentation. I also want to thank those of you who have supported me over the years to really think critically about HIV and health. In particular, I want to thank the community of Black people that I've been part of and our dedicated allies who have taken the trouble to live this journey with us. But I'm also offering special thanks to my friend, the late Davika Hinson. Davika was someone who was relentless about advocating for Black leadership of a Black community-based response to HIV. So I will begin with a simple diagram that dramatizes, I think, how Black communities are disproportionately burdened by HIV in Canada. Okay. Now, why isn't my screen advancing? There we go. Yeah. So this diagram shows new cases of HIV among white and Black people in Canada relative to their population size nationally and in Ontario. I chose 2016 only because it was a census year. So look, for example, at the relative absence of diagnoses among white Canadians. 2 white people diagnosed per 100,000 white people in the population for Canada as a whole and also for Ontario. And compare that to what happened to Black people. 20 Black people diagnosed per 100,000 Black people nationally and 15 per 100,000 Black people in Ontario. Now, I believe that we can do much better than this. So today I'm going to reflect on the present to imagine an outcome that really and truly, I think, will value Black life in Canada. So I want to argue that Canadian responses to HIV have totally failed Black Canadians. And I want to propose a more radical or transformative approach. So I will anchor my presentation in 3 texts that have looked at Blackness and modernity in different ways. First, let us engage with Eric Williams. So Eric Williams was the first Prime Minister of Trinidad and Tobago. This excerpt is from his book, Capitalism and Slavery, that was published in 1944. And that book was actually based on his PhD dissertation at Oxford University in 1938. And Dr. Williams wrote, "The prosecution of the slave trade was not the work of the dregs of English society. The slave traders were among the leading humanitarians of their age. They held high office in England. What I take from this is that European enslavement of Africans in the Americas from the 16th to the 19th century was perpetrated by people, and both men and women, who knew exactly what they were doing. They amassed the wealth and infrastructure that produced capitalism and financed their own bottom line. Today, in a similar way, decent people reproduce the structures and frameworks for anti-Blackness. These decent people could be our neighbors or colleagues or managers, whomever. They're all decent and respectable in their own right. But what they do is to reproduce a way of life that systematically privileges them at the expense of Black people. Now, following Eric Williams, the second aspect of my conceptual background is this: that decent people rationalize their privilege by their belief that there is something wrong with Black people, rather than focusing on the system of oppression and disenfranchisement that they have reproduced. So Fred Moten expresses it this way: the cultural and political discourse on Black pathology has been so pervasive that it could be said to constitute the background against which all representations of Blacks, Blackness, or the color Black take place. Blackness has been associated with a certain decay. For the third component of my sort of conceptual framework or background, if you will, I will note that recently there has been much talk among decision-making elites about equality and even equity. This has been expressed in terms of the current mantra of EDI, equity, diversity, and inclusion. But what I think this does is to really avoid the kind of social transformation that is required to support Black life. Here's what Tommy Curry had to say about this. This is how Professor Curry expressed it. Despite the democratic prose of equality, the reality is that addressing the social inequities as they affect Black people requires real structural, psychological, economic, and legal change. In other words, elites engineer change that strengthens their license. So I will now come to one of the central aspects of my presentation, which is how has the HIV epidemic in Canada evolved over the last 40 years, but especially over the last 10 years. And we will cycle through a series of diagrams that really describe, I think, in a succinct way, what I would like to say, the point I would like to leave with you. Now, today, there are at least two distinct HIV epidemics in Canada. There is an entrenched and worsening Black epidemic alongside a disappearing epidemic among white Canadians, principally white gay men. The epidemic among Canadians mirrors what has been happening with new infections globally. So if we could look at that trend, this is the picture that we have from UNAIDS, consistent decline in new infections over the last 20 years, but we could actually stretch this back into the 1990s. So, since 1998, there has been a massive decline in new infections globally, and this is a good thing. This is where we all want to go. Now, in Canada, the picture is similar, if a bit more complicated. So you can see that at the beginning of this period shown here in 2010, there were 6.3 new cases per 100,000 people in the population, and by 2019, it has fallen to just about 5.5 new cases. This was especially true among males, but less so among females. In fact, if anything, among females, we can say that the situation probably got a little bit worse. New cases rising from just about 3 to almost 3.5 over the period. And a similar thing here in Ontario. I mean, if we look at the global picture, in 2010, there were 830 first-time diagnoses, and in 2019, there were 684, a decline of almost 20%. Of course, that decline was due to declining diagnoses among males. there's no such distinct pattern for females. If anything, some people might say, well, it actually got worse for females over this period. So in the meantime, then, while all this has been going on, this decline globally and nationally and in Ontario as well, HIV transmission among Black Canadians is unfolding contrary to Canadian and global trends. While white Canadians account for a diminishing share of new diagnoses, the burden of the epidemic among Black Canadians has been increasing. And this diagram and the next one, I think, shows this. You can see that according to the Public Health Agency of Canada in 2019, the share of diagnoses, the share of new cases attributable to Black people in Canada was almost equivalent to the share of new cases attributable to white people, even though Black people constituted just about 4% of the Canadian population, and white Canadians 2/3 or more of the Canadian population. So when we talk about, the disproportionate burden, this is what we mean. It is disproportionate seems, in fact, an easy way to describe it. What we're describing, I think, is more like a crisis than anything else. Maybe we should be talking about the crisis of HIV among Black Canadian communities. And in Ontario, the province of Ontario, that has most of the Canadian population and most of the HIV epidemic as well, you can see that, in 2019, Black people accounted for 1 of every 4 diagnoses in Ontario as well. So in other words, what I'm saying is that there's this trend taking place globally and nationally in Canada, but what is happening among Black Canadians nationally and in the province of Ontario is in fact that we are going against the trend, that HIV is becoming an even more serious problem among Black people. Now, this has implications for our discourse about ending HIV, because clearly current trends indicate that HIV will end for many people, but current trends indicate that HIV will not end for Black people. That when the end of HIV comes, these inequities will still be large. And I fear that when that happens, Black people will be left on their own then to deal with HIV without the resources, without adequate resources being available. So let's unpack these trends a bit and look at how they unfold among males and females and so on. So, when I look at these trends, I say white people get health and Black people get HIV. I must also say that when we look at these trends in Ontario, there's an important report that was published in December last year. And so in preparing for this talk, I started asking my friends about whether they had actually seen the report, people in my networks and people who should know, and nobody seemed to know what I was talking about. So I figured I had to present this in a bit more detail than I usually would in order to start this dialogue about what this crisis means and where we go from here. So let's start. Okay, why can't I move? There we go. So what this diagram and the next one shows, the number of cases and the proportion of cases, is the consistent decline in new cases in Canada attributable to white men versus what has been happening to Black men, and the decline in cases attributable to white women versus what has been happening to Black women. So the result of that then is that, Black women in Canada account for about half, certainly more than 40% of all new cases among women. And Black men account for about 1 of every 4 cases among men in Canada. While on the other hand, the proportion of cases attributable to white men has been falling. The pattern is similar for Ontario, and the next 3 or 4 diagrams that we will cycle through, please look at the pattern more than the actual number. But when we're talking about males, the pattern that we've just described for Canada as a whole is more or less the same. So that by 2019, Black males accounted for almost 20% of new diagnoses among men, whereas white men accounted for, distinctly less than half. Among women, it's a similar thing, except of course that HIV among women is essentially an issue of HIV among Black women. So by 2019, Black women accounted for Black females accounted for close to 60%, 6 of every 10 new diagnoses among females in Ontario. And if we look at gay and bisexual men and other men who have sex with men, it's a similar pattern. You can see that over this period, 2014 to 2019, while the proportion of cases among men has been falling, in this population of GBMSM, the proportion of cases, diagnoses rather, attributable to Black men or Black MSM has actually been rising. So then, the trend in Ontario is similar to the national trend, but perhaps a bit more pronounced. As a result, whether through same-sex or heterosexual contact, Black males and females account for a hugely disproportionate and increasing share of new diagnoses from year to year. By 2019, in Ontario, heterosexual contact accounted for 2/3 of new diagnoses among ACB people, while male-to-male contact accounted for the remaining 1/3. This is quite different from the pattern from the trend among white Canadians, where new diagnoses have been largely due to male same-sex contact. But there are a couple other considerations that underscore the inequity that emerges with HIV. First, you might have noticed for the Ontario data, but this is also true for the national data, you might have noticed the large number and the large proportion of cases with unknown ethno-racial background. Now, many of us understand that this unknown category is substantially Black, which suggests that the burden of HIV among Black communities may even be more oppressive than the data actually suggests. The second thing to note is that our trends suggest that the prevalence of HIV among Black Canadians may be quite high by Canadian standards and even by international standards. In other words, there is no way that Black people could consistently account for 1 of every 4 or 5 diagnoses without raising the prevalence. And I think some of us already have some evidence, in fact, that certainly in the 2 largest cities in Ontario, the prevalence of HIV among first and second generation Black people might be way more than 1%. And remember, 1% is significant because it is that 1% that epidemiologists have used to designate this category of what has been called HIV endemic countries or serious epidemics in Africa and the Caribbean compared to elsewhere. So what if, think about this, what if in Canada, among Black people, we had an epidemic that was more or less on the level of some of those epidemics that the world has been concerned about in sub-Saharan Africa and the Caribbean? What if that was happening right here amongst us, among Black people? What would we think about that, and what would we do? But there's one other thing that I want to draw your attention to, and we'll come back to part of this later. But disparities in diagnoses are matched by inequities in care and treatment. Now, in Ontario and federally, when you ask about the care and engagement cascade, there's always the response, well, we don't have data. There's no data about that. This to me, for Black people, that is, there's no data for this about Black people up on the cascade. I find this puzzling because if we are talking seriously about ending HIV in Canada, how can we not have data on the cascade for the population group that is probably most affected by HIV in Canada? It makes no sense. But anyway, some of you may know that last year, a group from the University of Manitoba published what they call an equity analysis of how different population groups experience the cascade. Their results showed that Black people living with HIV in Manitoba were significantly less likely than their white counterparts to be in care or on treatment, which then means that Black people living with HIV were less likely to achieve virological suppression. If Black people are not benefiting from the cascade, HIV will continue to spread among Black communities at rates that are higher than among white Canadians. And Black people who are living with HIV will not reap the benefits of longevity or livelihood that accompany virological suppression. In short, there will be no end to HIV for Black people. So what motivates the trends that we've just been outlining? This brings me to the issue of structural violence. So in a fairly straightforward way, this is how I define structural violence for purposes of this presentation. Social arrangements, along with supporting ideologies and practices that systematically disenfranchise specific groups in a society, for example, Black Canadians, that promote social inequality, that is, that deny those groups access to equitable livelihoods, that reproduce the power and supremacy of the dominant group as their inherited domain, and finally, that reward the dominant group while that group reflexively interprets the disenfranchised group as undeserving. So that's my working definition of structural violence. Now, the federal government have acknowledged, I think, the impact of structural violence on Black Canadian communities, even though the federal government does not use that language. So, for example, this report that was published in 2020, just a couple years ago, Black women and men's labor market outcomes have generally not improved between 2001 and 2016. As a result, Black people generally live in more difficult economic conditions than the rest of the Canadian population. And just by the way, if you want a really accessible primer on how structural violence operates in the labor market, I will refer you to this article by White that was published in The Atlantic in 2015. So between 2001 and 2016, then, some people may say, well, you know, maybe all categories of Canadian workers were worse off. You know, everybody was affected. Something was happening that affected everybody. And this might be true. Now, I don't know, I'm not able to assess the truth of that claim, but it is plausible anyway. Except that for Black people in Canada, where we began in this period, where we started in 2001 or at the start of this period, is not where everybody else started. So here we have a rendition of the working poor among Black men and Black women and white men and white women in Ontario. So it is true that over this period, you know, Black men got worse off in terms of the rising proportion of working poor. Black women got worse off, so did white men and white women, but they didn't all start at the same place. In fact, some people might surmise from this that the disparity, the inequity actually got worse over the period. So, you know, sometimes when people say, well, you know, that can't possibly be true. You mentioned something and some measure of inequality, and people say, well, that can't possibly be true because other people experience the same thing too. Well, of course, other people experience the same thing too. But what they experience is not baked into how Canadian society functions. People experience things as individuals, but other people experience things as the groups that they are. And this is what we mean by structural violence. We don't mean that necessarily white people never become unemployed or white people are never poor. That is not what it means at all. But what it means is that poverty, all of these indices, these measures are really structurally determined, and they affect us as a large group of people rather than merely as a set of individuals. So there's one other thing about structural violence that I'd like to draw your attention to. And it is that racism is a routine experience for Black Canadians. So some of us were involved in the AC study in Toronto and Ottawa in 2018, 2019, among first and second generation self-identified Black Canadians. So in this study, 60% of the participants reported at least one racist experience in the past year. And remember, this is just first and second generation. So 6 out of every 10 participants reported at least one racist experience in the past year. We also found that racist experiences were more likely to be reported, as I should say, as participants' social status improved, as the social determinants of health became more accessible to them, as participants became more exposed to mainstream institutional life, and if they identified as LGBTQ. And one other important thing is that racist experiences were associated with accessing healthcare. So there are two main lessons that we draw from this. First of all, that in Canada, upward social mobility does not protect Black people from experiencing racism. It is important to understand that. We do not escape racism merely by getting better off, or we do not escape racism by living in Canada longer, or we do not escape racism because we are born in Canada versus being born elsewhere. That is not the story at all. As we get better off, as we get more quote unquote integrated in society, in fact, racism, our experience of racism continues. The second lesson we can draw from this is that the healthcare system is itself a source of racism that may amplify health inequalities. So then, structural violence does not sort of arise spontaneously. Of course, it didn't just come with oxygen. It is reproduced by the things that people do, the decisions that we make in this society. So research and decision-making elites in Canada actually reproduce structural violence in their dealings with Black communities. In other words, structural violence informs their actions with respect to Black communities. And what do we mean by this? Elites, these decision-making elites interpret Black communities as defective. In other words, Black communities are a problem, they're not an asset. We are defective. We are in need of correction and control. These elites also usurp the role of community leaders. They make decisions. In doing so, they make decisions behind the backs of Black communities or over the heads of Black communities. And when they do this, they effectively expropriate the value that resides in Black people's lives. In other words, these decision makers create social capital from Black people's disenfranchisement. That is essentially what I'm saying. And these actions and activities take place within this, what we might call a neoliberal agenda of personal responsibility, which goes something like this. You are not doing well in this society. You're at the bottom of the pile because you're lazy or you're indifferent. You don't know how to behave. You don't work hard enough. And furthermore, the state doesn't really have any special role in helping to strengthen your welfare and your well-being. So within this framework then, I think that we, and when I say we, I mean Black stakeholders or people who claim to be leaders in Black communities. We need what I call a renewed insurgency to radically transform the status quo. What we need to do, we have lived by this racial contract since the 16th century, since the dawn of transatlantic slavery in the 16th century. We have lived according to this racial contract that has really assaulted our humanity. Now, and we need to upend this. Many people will say, of course, well, that's purely aspirational. It's kind of pie in the sky. To some extent, it probably is. But I think, what I would also say in response to that is that every journey begins with a step, right? And this is the step that this is how we must begin this journey, so to speak. Yeah. So here are the first steps that I think may redefine our path. What we as Black stakeholders or leaders in Black communities, what it is we need to do. So how are we going to change the trajectory of HIV among Black communities? First of all, I think that those of us who are involved and interested in changing the trajectory need to critically reflect on the current conjuncture. And here are a few observations that might help us understand how we got here and how we can move on from this point. So, has the standard community-based response to HIV run its course? In other words, if we continue to do what we are doing, are we in fact going to become better off? Are we going to get to the place where we want to be and where we deserve to be by following this community-based response that more or less in one form or another has been in process for the last 40 years? Maybe it's time to think about whether we need a different way of responding. And I will suggest some ideas about that. Is it time to sort of give up on this, what people call AIDS exceptionalism? Is HIV really your problem? I mean, HIV is a problem, but it is not necessarily the fundamental problem that we face. And we know this because COVID came along in the last 2 years and did the same thing in Black communities that HIV has done for the last 40 years. So we know that it is not just HIV. So this idea that we are essentially fighting against HIV, I think we have to give up that. And we have to refocus, really go upstream, so to speak, and focus on those conditions that really make us vulnerable to HIV, COVID, et cetera, et cetera, et cetera. The third thing is that we cannot just turn up for work every day and sort of reinvent what we are doing on a daily basis. That is not good enough. So have we articulated, so what we need to do, I think, is to articulate a conceptual or philosophical core that grounds and guides our work. We must believe in something. So what is that? What do we believe in? What is motivating us? What is it we want to achieve? Can we think about these issues instead of just sort of turning up every day? Because when we turn up every day, what happens to us is then we are at the whims and fancies of decision makers, of policy makers, of funders who will tell us, do this, do that, do the next, do this, whatever. And we have no way of responding because we haven't really thought about what it is we're doing. We would have in fact have surrendered our leadership, surrendered our self-determination to the whims and fancies of a set of decision makers who essentially know nothing about Black communities. Now, the fourth thing is, have we done our best to meaningfully engage Black communities? Have we done enough to create movement? Do we have a communities or a community behind us? Because if we don't, it means that when we turn up to deal with these people who make decisions, whether they're making decisions about research, about programs, about policy or whatever, it means essentially we are turning up as individuals. We are turning up, in fact, from a position of weakness, not a position of strength. And the only way we can turn up from a position of strength is if we have Black communities behind us. And finally, have we done the best that we can to strengthen our collaboration as Black stakeholders? Do we have shared activities and perspectives? Do we collaborate to mobilize resources? All of these things, these are things that we need to think about. And if we think about these things, then we might be able to fashion a new framework or new directions to guide what we're going to do, what is going to get us from here to the place that we ought to be. So the first thing I note is, the need to a new way of thinking about Black leadership and asserting Black leadership. Too often, in fact, always, people get together and make decisions about Black health and well-being, and we are not even in the room. And even sometimes when we are in the room, we are so grossly outnumbered and so grossly outflanked and so grossly outmaneuvered that at the end of the day, when we receive the reports of what decision was made or what was discussed, we can't even see our voice in there. We cannot surrender our autonomy. We cannot surrender our self-determination to others and say, okay, this is all right. You go and meet in a room where we are not present. You meet in networks where we don't exist and make decisions about our health and well-being. This is not enough. So this is why I think that asserting Black leadership in decision-making about Black people's health is absolutely essential. Now, of course, research is, absolutely important for moving forward as well. But, all of our interventions and innovations need to address structural disadvantage. We cannot just say, let us roll out PrEP. Let's have a new testing campaign without understanding, how are Black communities going to access these things? What are the barriers standing in people's way to prevent them from accessing these things in the way that we think they should? That gets in the way of people making the kinds of life-enhancing choices that we know they're capable of. That is what we have to do. So we cannot put our faith, for example, in the engagement cascade when we know that it will not work for Black Canadians, simply because white decision makers told us to. If there is a cascade, and I believe in the cascade, but the cascade only works for us if it really addresses the structural barriers that Black people face in accessing services, accessing care and support, in maintaining their treatments in order to achieve virological suppression. On the subject of research, I think that there's also something to be said for a different way of understanding how research is funded in this country. This neoliberal way that research is funded. Well, first of all, let me say that research was never meant to include Black people as researchers. I mean, these things were not set up to accommodate us or to cater to us or to bring us in. They were set up, all of these rules and regulations that we have about how research is funded, how people get hired in universities, how people get tenure. All of these things were set up effectively to keep Black people out. So when we talk about EDI, I don't know where we're going to go with this if we're not willing to examine all of these rules and regulations and policies that really were not set up to accommodate us in the first place. But on the subject of research funding, given the kinds of issues that Black people face, it is simply not good enough in this day and age to say, for a research funder to say, here we have this amount of money, and we are going to invite everybody from all over Canada to apply for this money. And it's a competition, right? So, the people who are on top will get funded and the people who are at the bottom will get nothing. How is that going to serve Black people's interests? What we ought to be doing is to be sitting down with CAHR and all these people who fund research and determining, okay, you know what? What kind of research do we need to deal with the current crisis that we face? What is this going to cost and over what period of time? So are we talking about $10 million over the next 10 years or 100 million over the next 20 years? I don't know. I'm just pulling those numbers out of the hat. but we ought to sit down and say, what does it take? Research is important to the way forward. We need research, but just depending on the vagaries of a competition is not good enough. That is not going to help us. At the end of the day, we will be the same. So what is it going to take for us? Now, if this is what it will take, $10 million over the next 5 years, I don't know, whatever. Let's protect that money. And let's come up with a process whereby the people who can deliver can access that funding, instead of saying, well, just come and compete. And if you win, you win. And if you lose, you lose. But you might lose because there's only so much and everybody is asking for the same dollar, but you're not going to be any better off at the end of the day. I think we can do better than that. The third thing is about funding, how funding is allocated. Black people have been underfunded in terms of the response to HIV from the beginning of this response. I know people will come and say, but we gave you all this money, blah, 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 blah. Well, that is essentially an untruth. It is not true. Because I know from participating in these communities how we have gone beyond the call of duty. We have risen to the challenge without adequate supports from governments or research institutions. We have responded to HIV with an enormous effort that is often unacknowledged and unrewarded. In fact, most of us, I will tell you, work for peanuts while we see our white counterparts reaping the benefits. Not just me personally, but all the people I know work for nothing, providing services in an aid service organization, while other people who know absolutely nothing about Black communities sit elsewhere and tell us what to do. The fourth thing is really about data. Now, there is already a framework to sort of talk about this, and I've given it as a reference there. But here we are in 2022, and Black people have little control over their own data. Our data are as inaccessible to us as the social determinants of health. Others collect our data, decide how they will use it, construct a story that suits them, and here's what they do. They call some of us, they handpick some of us and call us into a room. And then they say to us, we are going to share these data with you, but you are not allowed to tell anybody about it. In other words, they call us into a room, throw out some tidbits, and then say, you know what? If you tell anybody about this, we're going to punish you. So we have these data, but we're not going to allow you to use these data to develop the kind of programs and policy and advocacy and so on that you should be doing. No, we're going to punish you if you share these data among your networks. Now tell me if that is something that we should be proud of, if that is something that we should encourage. Some of the data that I have presented here is from OHISI, the Ontario HIV Epidemiologic Surveillance Initiative. First of all, I don't know why people think it is a good idea that surveillance and Black people should be used together in the same sentence. Now, I know epidemiologists will say, oh, it's a technical term and blah, 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 but really, you're not doing Black people any favors by using surveillance in association with Black people, ever, but especially in this day and age. But let us move on from that. So I want you to go on the website where OHISI publishes these reports and look at who OHISI is. And tell me if you think that that's good enough, that these quote unquote experts should be assembling Black people's data, their surveillance, then they treat it as their own. If you ask any questions, they get upset, threaten you, et cetera, et cetera. And this is their data. You have no, they're the experts. I don't know how this has come about, but I don't know why it should be allowed to stand. So, in these instances, what we need is that there is a committee of Black experts, and there are experts out there. Trust me, there are some that really exercises leadership, that sits in the room and talks about what this quote unquote surveillance means and what these data are all about and how they will be collected, how they will be curated, how they will be shared, but goes a step further and works with people working on the front lines to ensure that they understand these data and they can use these data in the ways that really promote emancipation and liberation. That, I think, is where we ought to be going. So I'm going to end now, but I'm going to say to you that what I've tried to show is that there are these global trends in Canada, trends in Ontario, diminishing. HIV seems to be heading somewhere, diminishing, heading to an end, as they call it, but not for Black people. Now, some of us, and we call ourselves the Ad Hoc Committee on HIV in Black Canadian Communities, have already started the process to critically re-examine how HIV has emerged among Black Canadian communities over the last 40 years, but also, quite importantly, to develop a transformative agenda to change the trajectory of HIV among Black communities. We have developed a draft manifesto which Black researchers and service providers and people living with HIV and community advocates and others, students, for example, discuss at a special session of this conference on Tuesday. This is the start of a process to engage our communities in bold, inspired, creative, and self-determined leadership of policy programs and research to address HIV and health in Black Canadian communities. We have embarked on this process because Canadian responses to HIV have failed Black communities, and business as usual is not an option. So the time has come. Thank you very much.
Thank you so much, Dr. Husbands. That was an amazing presentation. We're getting a lot of comments from the audience, and thank you for loud clapping. Yeah, I wish we could, right? You deserve a standing ovation for that talk. We have a lot of comments from the audience saying brilliant presentation, delivering some much needed truth. Excellent. We need to re-examine our responses. Brilliant. Thank you, Dr. Husbands. We also have some questions beginning to come in. One is a question about a very specific slide, slide number 11. If these are all new affections acquired in Canada, where do you think they are acquired? And what is the narrative behind these new infections?
So let me look at number 11.
Thank you.
So what is the question again? Were they acquired in Canada?
Yes, let me read you the specific questions. The question is, okay, so on slide 11, are these all new affections acquired in Canada?
No, I cannot say that they're all new infections acquired in Canada. I can say, however, that the majority of them probably are. But for data from the Public Health Agency of Canada doesn't break down new cases according to prior evidence of HIV. The data from Ontario, however, when we talked about males and females and gay and bisexual men and so on, those are all what they call new infections. So there was no prior evidence of an infection. But I must say, however, ever since I became involved in this work, people have raised questions about this idea that HIV has been brought into Canada by people who, whatever, Haitians and Africans and this and that and all that. In other words, there's a narrative that HIV is not really a Canadian problem, it is an imported problem. Now, I think that the response to that would be to do something about immigration, stop people from bringing this problem to Canada. But I'm not sure that people have actually brought this problem to Canada. This is a Canadian problem. Of course, there are people who were living with HIV before they came to Canada. But some of these people who are also in my network have turned out to be exceptionally productive people, despite the challenges that they've had, being in Canada, being new in Canada, living with HIV, having difficulty understanding the landscape for services and treatment, et cetera, et cetera, et cetera. So I would urge people not to, while there's no guarantee that all of these, for Canada as a whole, that all of these new cases were acquired in Canada. The data that I was showing for Ontario is only for cases where there's no prior evidence of HIV infection. In fact, new diagnoses, so to speak. Yeah.
Yeah, I think you raised an excellent point about where the infection is acquired. Seems irrelevant to the point that the person has HIV and needs to access care, and that we need to be concerned about it in our country. Are there any, if there are any other questions for Dr. Husbands, I'll ask you to please put them in the chat. We're receiving many thanks. Again, thank you for a brilliant and powerful presentation. Deeply appreciating the framing of these issues. There's a need for significant changes in how leadership and funding are affecting the lives of Black, African, and Caribbean people. A specific question from Mara Villa. Your data focused on HIV cases. Do you have data between the Black population versus Indigenous groups? What are the risk factors for acquiring HIV for Black populations?
There is comparable data about Indigenous peoples, but of course, I'm not the one to really speak of that. I think that Indigenous people can sort of make their own story, but there's similar data for Indigenous people that is available in Ontario, but also federally. And what was the other part of the question? What?
The other part of the question was asking about risk factors that may be unique to Black populations, or at least more prevalent.
Yeah, so of course there's risk, and risk is about the kind of sex that people have, and whether people inject substances and so on and so forth. But if you step back from that, there's also the issue of vulnerability. What are these factors that make certain people more vulnerable to HIV than others? And that's where we start to talk about the social determinants of health. That's where we start to talk about structural violence and so on. Just like COVID, there are risk factors for COVID. And so people say, well, in these neighborhoods where there's a large Black population, you get a lot of people living in a small living space. So that's how people get COVID. But really, then you have to step back from that and say, well, why is it in Canada that you have a large number of people living in a small living space? That is where we start to talk about vulnerability. So I think it is important to really make that distinction. And there's room for talking about risk. But of course, in order to deal with risk, we also have to deal with vulnerability.
Thank you. You're receiving more standing ovations in the chat group. A question from the audience is, what do you see as the roles for allies in supporting this transformation in leadership and approach?
Well, we've always had allies. There are people who have been allies, as I said, allies who have, walked this life with us, so to speak. And I think that allies bring all kinds of talents and all kinds of enthusiasm to the cause. It could be technical expertise. It could be, all kinds of people have played. Really, some people who are not Black, many people who are not Black have gone beyond the call of duty in really identifying with this cause, and that's good. There's a room for allies, but really, and allies are important, and allies walk this walk with us and play this, resist with us, and develop programs and policy and help us do all the things we need to do. without necessarily taking over our place, if you will. Allies are allies. They're not there to come and take over. That would be a new form of colonialism. They're not just to take over. But, my main point is not about whether or not allies are good enough. My main point is about the decision makers and how decisions are made, whether they're about policy, research, or whatever, that are made by people who have no superior knowledge of Black communities, and they're made in the absence of Black people. They're made in places where Black people are not present. They're made above our heads and behind our backs, and what happens is then that we turn up, and these decision makers insist that we must follow, quote unquote, the rules. And this is clearly an instance in which, we say, let's treat everybody the same. So CAHR will say, we have this $10 million for this competition, and we have these rules. So let's treat everybody the same. But in treating everybody the same, it means that we end up effectively marginalizing some. And that is not good enough. If we're serious about getting where we are, the idea, we must really be careful. I'm not saying that there's no room for treating everybody the same, but we must really be careful about this, and we must really approach this critically. What does it mean in this instance to treat everybody the same? That's the main emphasis of what I wanted to say.
Thank you. There's more positive comments in the talk. Thank you for your powerful presentation and identification of strategies of how to change and move forwards. And it's transformative thinking and doing research that's really needed. One question that came from the audience is, do you think that decision makers are ready to address an HIV crisis that is specifically addressing Black and Indigenous people?
So they might not be ready, but I think it is up to us to make them ready. They might, one of the dangers of this discourse about ending HIV is that the way how we talk about this and the way how HIV is likely to end, then the resources go elsewhere. So the people who are left with HIV, Black Canadians, Indigenous people, and so on, may be left then without the resources to sort of deal with this in the way that it ought to be addressed. But I think, it is up to us to make decision makers stay at the table, to really force that issue, that just abandoning, moving away from the table or walking out of the room is not good enough. It is not an option. And, we have tools in order to sort of force that issue. The problem is but these tools come with a risk, of course. These tools come with a risk, and there's risk all around. And it is the extent to which we can tolerate the risk of using the tools that we have. Like, for example, we can say no sometimes to, if decision makers say, we want you to do, AC study, for example, that I mentioned is a case in point. You know how long it took us to deliver that? Because people at PHAP were saying, we're going to give you this money to do this study in this particular way. And we said, no, but we can't do it like that. And they said, no, you have to do it like that. If not, we're not going to fund you. And they keep saying, no, you can't do it like that. And we kept saying, they kept saying, no, you must do this the way how we tell you. And we kept saying, no, it can't happen like that. And eventually we were able to do it because we didn't get up and walk away. We simply stuck to the task and made our point. And we were strategic about looking for resources elsewhere as well, so that at the end, we were able to do this thing, in the way in which we thought it should, the way in which we said it would be done. Because really, we were the experts about doing that. We knew how to do what we were proposing to do. They didn't know, but their power came from the fact that they had the resources. But what I'm saying is that sometimes we must be prepared to say no, and sometimes we must be prepared to sit and really argue our case instead of capitulating. but there's always a risk that comes with that. And it's the extent to which we are able to withstand, to sort of sustain or manage that risk.
Dr. Husbands, I actually have a question. I have often felt that there is something wrong with the funding model for scientific research that is where it feels as though there are inefficiencies. And I wonder, and I have often challenged myself to come up with a better funding model. And I fully agree with your criticisms of how the competitive funding can potentially just continue inequities, structural inequities. Do you, and I think, of course, the challenge is what is the alternative strategy? Do you have any, putting you on the spot in the last couple of minutes of your brilliant presentation here, do you have any suggestions for what a better funding model would be?
Well, I do. I don't have all the details or all the answers, but I think that certainly in the case of Black communities in Canada and HIV, and it could be extended to other things as well, there needs to be a discussion about, the seriousness of the issue that we face, the role of research in addressing that issue, and what that is going to cost. So let us, before we have all this competition and say, any and everybody apply for this pot of money and whatever, and then let's sit down and say, for Black Canadians, certainly, do we agree that what the problem is? Do we agree that a certain kind of research or research in general is really important to understanding and addressing this problem? Okay, now how much is this going to cost over, if we had $10 million over the next 5 years, where would this get us? And have that kind of discussion so that we arrive at something that says, you know what, over the next 10 or 20 years, here's what we will do. And at the same time, we come up with a process to say, okay, this is a process now to make sure that this money gets into the hands of scholars who can really deliver. And I don't know exactly what that process will be, but it is not, we're not talking about sending a person to Mars here. We're talking about a problem that is familiar to us and the kind of problem that we have solved before. So that's one kind of approach, because I'm convinced that this idea of just having a competition and everybody can apply. And as you know, even in the best competitions, there are brilliant proposals that never get funded. Brilliant. Because there's only so much money, right? And funders will tell you this. They'll tell you, well, we only had, $10 million, so we could only fund, 5 or 10 of these things. But there are actually another 10 that really deserve funding. So that is a really inefficient thing to do. And it really wastes talent as well. Perhaps not just for Black Canadians, but all around.
Yes, I agree with you. Very inefficient. So I'm getting dinged by our technical support, who's asking me to wrap up because we're out of time today. I think I speak for everyone in attendance. That was a brilliant presentation, Dr. Husbands. Extremely important information and words that you provided to us today. So I wish we could all stand up and give you a standing ovation. Thank you so much for your time.
Thank you for inviting me, and thank you and Lawrence for inviting me. It was a pleasure to speak here today. Thank you very much.